front, but we want to make sure that everybody can see some of our slides. We've got some data that we're going to be sharing with you, but then we're going to talk to you a lot about some of the programmatic aspects of our maternal mortality review program at the Arizona Department of Health Services. So we do want to say thank you to the fourth trimester for having us here. We know that maternal mortality is not the most uplifting and exciting topic, but we are going to do our best to embody the energy of today and send you some positive vibes, and hopefully have all of you leave here with a very inspired and hopeful outlook on the future for Arizona women. So with that, before we get started, I would love to know, this topic has been floating around today, it's been floating around other areas. I want to know, like, what do you think about when you hear the terms maternal mortality? Where are you hearing it, and what do you know? Anybody want to share? Yes. Excellent. Thank you. Anybody else? Where are you hearing these terms? Where are you seeing them? Awesome. So it's getting out through social media. That's great. Are you going to say something? Mm-hmm. Awesome. Yeah, so another community partner really pushing this, pushing for awareness among women, women and families really. Any other thoughts? No? All right. Well, I was going to, let's see if this. I just pushed the wrong way, sorry. So we did want to highlight that, yes, the media, social media, community groups are really taking hold of this issue and trying to raise awareness across, women and families in our country, and rightfully so. The data is showing that maternal mortality is rising, and Kate's going to talk to you a lot more about all of those things. But what I want to say is, even from a personal perspective, the fact that this issue is really taking off isn't entirely a bad thing, because it really has forced our federal partners, state partners, community partners to really think about this issue and tackle this issue in a way that we haven't before. So our goal for today, like I said, Kate's going to walk you through some of what's happening with women in Arizona. She'll walk you through some of the data, but we don't want to let that weigh you down too much, because we do want to end by talking about some of our efforts to improve maternal health outcomes in Arizona. We've got some exciting programs that we have going on right now, some new funding, some new resources. So we'll talk to you about those and our goals. So with that, I'm going to turn it to Kate.
Okay, and again, my name is Kate Lewandowski. I'm a maternal and child health epidemiologist at the Arizona Department of Health Services. So my job in all of this is to do the ongoing surveillance to see what is happening amongst our women and mamas given birth, and in that whole period. And then in addition, I also help support our programming that's going out to improve those outcomes and to review the deaths and making sure that they have all the data they need, and that we're also monitoring how successful those programs are going to be in the next couple of years. So just to give an overview of 2018 births here in Arizona, total births, we had 82,500. Amongst Arizona residents specifically, there was 80,530. Approximately 51% of those births were paid by the Arizona Healthcare Cost Containment System, which is the Medicaid agency here in the state. Approximately 27% had C-sections. About 16% had already had 2 or more previous live births. More than 16% were over the age of 35. About 12% gave birth less than 18 months between since their previous birth, so very short intervals between those pregnancies. More than half were overweight or obese. About 2.8% had no prenatal care at all. And then about 5% had early non-medically indicated deliveries, which is either being induced or getting a C-section without any of the medical reasons that would indicate the need for getting an induction or a cesarean. So those could be elected cesareans that were scheduled, or those kind of situations. So now just to give you some of the data specifically around morbidity and mortality. So just to give a preface, maternal mortality, when we say that, it refers specifically to the death of a woman while pregnant or within 1 year of the end of pregnancy, regardless of the outcome. So whether she had a live birth, she had a miscarriage, or any other outcome. and also regardless of the duration and site of pregnancy, from any cause related to that pregnancy or aggravated by the pregnancy or its management. So this does not include things like car accidents or drug overdoses that are not related to the pregnancy. Severe maternal morbidity is an unexpected outcome of labor and delivery, such as hemorrhage, organ failure, and stroke that lead to significant short and long-term consequences to the woman's health. And those are both definitions from the CDC that we adhere to here in Arizona. So it's good to kind of think about maternal health outcomes as a spectrum. So at the very base, the majority of births and labor and delivery that happen here in Arizona and in most of the world and in the country, you have uncomplicated deliveries. So these go as expected, everything's good, everyone's happy and healthy, they get sent home, and they live their life without any hiccups. Then you have maternal morbidity as a whole, which these can be some unexpected outcomes. Maybe someone ended up getting a cesarean section when they weren't planning on it, something came up. But otherwise, it was relatively uneventful. Mama, baby still did okay, and then they got sent home, maybe a little longer than normal, but still moderately okay. Then you have severe maternal morbidity, and that's where we start really looking at the numbers of that. Those are cases where something pretty significant has happened. If they had a significant hemorrhage, or they had to get an unexpected other procedure such as a hysterectomy, or there's indications of organ failure or shock or sepsis or something that's a little bit bigger than just a hiccup. And those usually mean that they're in the hospital, maybe a couple extra days, up to a couple months. And those are when we start to see the long-term health outcomes as well, kind of leading into the rest of a woman's life. And it also has impacts on her baby. We have maternal near misses are those cases where those morbidities are so severe that had the interventions or the treatment that the healthcare providers provided, if that hadn't happened, she would have died. So those are those women that are, brink of death situations. We managed to save them, but that's still not a positive outcome. Not dying should not be the goal. We should make sure we're trying to keep people as healthy as possible. And then at the very top, you have those maternal deaths. And that's obviously the last thing that we want to happen. Obviously, keeping people alive, that's a good goal, but we also want to make sure everyone's surviving and thriving and having a good life. In the United States, for some reason, we've continued to have this issue of either relatively stable maternal mortality, you can see in the 90s, and then in recent years, in the last 15 and ongoing since this graph, we continue to have an increase in our maternal mortality rates. And what's most surprising about this is that this increase is not happening in other developed nations. So not only are they decreasing and doing well and having relatively low rates, we're increasing, and in a lot of cases we're actually doing worse than developing countries. So we're not only like last of the pack of these countries that are more of our comparisons, financially and resource wise, but we're actually just overall in the world, we're not doing great. And that's of course alarming, and that's what's gotten a lot of the attention that Clarke had mentioned before. So obviously maternal health is a very complex issue, right? There's not one reason that this is happening, but that also provides a lot of opportunities for improvement in a variety of areas. So you have some that are specific to the provider, and this can do with training. This has to do with delay in timely diagnosis and treatment, in having practices like those cesarean sections without a medical delivery. That's just inviting complications to something that maybe didn't need to be performed. And then you have patient level factors, which this has to do with things like increased age or parity, or some of those risk factors we just know already give mom kind of an increased chance of having something go wrong. This also has to do with the pre and interconception health status. So if you have a woman that already has some chronic health conditions, she's not at peak health anyway, then when she gets pregnant, that's already putting her at a disadvantage. So that's a piece of it. And then we also have system level factors, and this is obviously things like discrimination and racism, but it's also, lack of continuum of care between well-woman visit into prenatal care, into postpartum care, and then back in the cycle. Standardized data collection even, or protocols in a hospital or facility level. So there's a lot of things going on, and it's not just a woman being isolated in her little situation that goes wrong. So there's lots of pieces happening, and it's tricky, to measure that and to feel, sometimes it can feel overwhelming, but it also means that there's a lot of areas that we can make improvements. So it's going to be a major team effort. So one of the pieces that we know can make a difference in maternal and infant health outcomes is access to care. And so this goes all the way from before she gets pregnant through her pregnancy, and then, of course, that postpartum visit. So just among women aged 18 to 44 in 2017, you can see that women that are receiving their well woman visit, their preventative medical visit every year, we are way below the national standard, and we're way below where we want to be. So in 2016, only 61.5% of women in Arizona had that preventative visit. So if you're a woman and you're not getting that visit, and maybe you have health conditions that are not being managed, then if you get pregnant, whether intended or not intended, you weren't planning on it or you were, then you're already kind of having that to then catch up on and deal with, rather than, having something like diabetes where it's under control and you're in a really good place to get pregnant. In the U.S., the total for 2016 is 67.4. So still fairly low. We would love that to be a lot higher for our mamas, but that speaks to women's limited access to healthcare in the U.S. right now. Part of this as well is among women that had no prior pregnancy, so women that have just never had a baby before, the number that received advice from healthcare professionals about achieving a healthy pregnancy, whether that was planned or otherwise, being in a good place to get pregnant, amongst those, 20% did not receive any information. So that's 1 in 5 women that are going to those visits. Amongst those that manage to make that happen, they're missing the information. So if they get pregnant unintended, then they have no information to go from, and that again is a poor beginning that can then lead to some of these poor outcomes. And then when a woman is pregnant, nearly 30% of women here in Arizona are not receiving the level of prenatal care that they should be. So using the recommendations from the ACOG, the American College of Obstetricians and Gynecologists, there's a certain number of visits that a woman should be receiving based on the gestational age of her pregnancy. And we see that 30% of women are not getting 80% of those visits. So there's a lot of gaps in the amount of care women are receiving during pregnancy. And that also, again, sets you up for, or it doesn't set you up for a poor outcome, but it doesn't give you all the advantages of preparing for the outcomes that occur or making sure you're at peak health throughout that time. Another issue, though, for accessing care here in Arizona is that the number of birth facilities we have here in the state and the number of trained providers to deal with maternal health care can be limited in particular areas of our state. So here in Maricopa County, we do pretty okay because there's a ton of facilities, there's a ton of providers, they're all relatively close to where women live. So if something goes wrong, even if a woman's at a birth center or, in a lower level facility, it can be transferred and taken care of within a relatively reasonable time frame. But if you're in, let's say, La Paz County, and you're in a rural facility, maybe they don't even have, they don't have an obstetrical provider there, and let's say you go into preterm labor, the timing to get the level of care you need is a lot longer. And so if something goes wrong, you're at a disadvantage because now you're beating the clock, right? So something like a hemorrhage that happens really fast, once you recognize that, then it's a race, right? And we want to make sure we're setting up these women for the best, and part of that includes care near where they live. So the March of Dimes conducted a study in 2016 births to see the level of care available to women. So they looked at a couple things. The first thing they looked at was the number of facilities that provided obstetrical care. So these we would refer to as birth facilities. And then they also looked at the ratio of obstetrical providers, which includes medical doctors and certified nurse midwives. And they looked at the ratio of how many of those providers were available compared to the population of women in that area. And so what they found here in Arizona is that La Paz County and Greenlee County neither have a birth facility and neither of them have any obstetrical providers. So that's problematic. So if you're living those places, if you're around full term and you have a birth plan and everything goes well, then great, you can head to a nearby county and a nearby facility and have a birth and everyone's great. Again, if something goes wrong, you're kind of, that's when we have issues. So in addition to what we would then call maternity care deserts, which are those 2 counties, we have areas of limited access to maternity care. So these places may have an obstetrical hospital, they may have providers, but that ratio of providers to women is less than 60 providers per 100,000 women, I believe is the ratio. And then in addition to that, they have less than 2 birth facilities. So again, there may technically be access, but a woman's ability to get to that access in a timely manner and receive the level of care she needs might be limited. So again, having this access to maternity care, having the level of care available to women all across our state is one simple step that plays into this whole picture. So one of the measures that I and my team have been conducting in the last year is looking at severe maternal morbidity here in Arizona. So again, this may be women who died a maternal death, but it also is those women that had some severe complication during labor and delivery that they may have survived, but still are going to have some ongoing health outcomes from that. For this, we look at something called the hospital discharge data. This is data that's reported by most facilities here in Arizona, the exceptions being birth centers and Indian Health Service facilities. And amongst those delivery hospitalizations during their labor and delivery, we look for those, and then we identified women that had one baby, so a singleton birth. And then within that, we flag essentially for these a list of complications, a list of different indicators or procedures that went on during that facility to give us a heads up that this was a severe maternal morbidity. And so amongst that, amongst the singletons for 2016 to 18, there was 117.1 cases per 10,000 singleton delivery hospitalizations. I think for this time period, there was like 2,558 severe maternal morbidities across our state. And that's just that labor and delivery period. That doesn't include any of the pregnancy, which we know can have complications that have some severe consequences. And it also did not catch anything postpartum. So even that same day after a discharge, any readmissions are not included in that. So it's just a limitation. It's something we're looking for in the future. But even amongst just that labor and delivery, we had 2,558 cases. So that's a pretty big deal and something we want to obviously reduce in the coming years. Some of the leading indicators amongst those included blood transfusions in most of the cases, 64%, adult respiratory distress syndrome in 8%, sepsis, DIC, which is essentially a hemorrhage, a hysterectomy, acute renal failure, pulmonary edema, and shock. And we have a total of 21 things that we're looking for, so the list goes on. And you can see for most of our women, 84.5% of those cases only had one indicator. So they may have just isn't the right word, right? Because it's still a big deal. They may have had sepsis, but only sepsis, or they may have had renal failure, but no other complication. But then if you look, we have about 15.5% of cases that had two or more indicators. So those are really those cases that could be those near misses. They had a lot of things happening, and that has a lot of implications for their health and for baby. And then looking at this by race and ethnicity, there's some major disparities. And this is consistent with what we see across the United States. It's consistent with what we see with other health outcomes, and this as well as maternal death. And in this study, American Indian or Alaska Native women had a rate of 292.6. And compared to our non-Hispanic white women, which was 82.1, I believe that's over like 3.5 times the difference in rate. So that's showing a major issue in this population. And not just them, we see increased rates amongst our Black and African American moms, as well as our Hispanic and Latina, and even our Asian and Pacific Islander. So that shows that even though overall we're doing relatively okay at 117.1, lots of room for improvement there, we see even more need for improvement in some of these other populations. Now switching into maternal mortality. This is that kind of top of the pyramid. These are women that actually are dying from these as a result at these events. Amongst pregnancy-related deaths, so those deaths that are related to the pregnancy or aggravated by the pregnancy, we see that, again, there's this disparity. So 70.8 is a maternal mortality rate for American Indian or Alaska Native women, and this is per 100,000 live births. So for every 100,000 live births, there were 70.8 women that died amongst American Indian and Alaska Native. And this is compared to our white non-Hispanic women who had a rate of only 17.4. So you can see, again, this is a massive disparity, and it calls need to improve not only the overall health of moms, but moms that are in some of our racial and ethnic minorities. Looking at some of the top causes of death for pregnancy-related deaths, cardiac and hypertensive disorders were present in 27%, hemorrhage was responsible in 24%, suicide, homicide, and accidents, which kind of point to that increased risk for mental health issues, and some other, domestic violence is prevalent, even more increased during this time period. So, I mean, that's still related, 16%. And then we had a combination of all the other causes in the remaining 33%. And the big take-home point, and this is from the process of reviewing these deaths with the Maternal Mortality Review Committee, which Clarke will mention in a moment, 89% of these deaths are preventable. When the committee of experts reviewed this, if something within a reasonable measure could have been done, these deaths, the outcome could have changed. So that's where it really gives us some purpose and a goal in moving forward, because there's something we can do and we just need to be doing better. And again, preventability just speaks to the idea that under reasonable conditions, something could have been done either by an individual, so whether it was a provider, or a community as a whole to prevent that death. And now I'm going to hand it back to Clarke, and this is the more positive part where we move into next steps.
Yes, thank you, thank you. So at the beginning, we did promise you that we were going to leave here on a more positive, hopeful, inspirational foot, and so this is our goal to do that. So Arizona actually established its Maternal Mortality Review Program back in 2011. So we've been doing this for a while, but it's been unfunded. So we have established a committee, a multidisciplinary committee of volunteers from across the maternal health spectrum. So there are, providers at the table, OBGYNs, nurses, nurse midwives, but we've also tried to pull in non-clinical service providers as well. So the police department, help me think about who they are. Healthy Start. Who else am I thinking of? Police Department, Healthy Start, Access, Law Enforcement, Indian Health Services, Matrescence. Thank you for inviting us here. So all of these people to come together and review these deaths. I'm going to talk to you more about that review process in a second, but we did bring back the triangle to just show that while our program does formally review every death that occurs in Arizona, we do that analysis of all those severe maternal morbidities as well that can almost tell us just as much about what needs to happen to prevent these outcomes and improve maternal health outcomes in our state. So this is what our review process looks like. We really think about maternal mortality reviews as being an ongoing quality improvement process where we take all of the presumptive deaths that occurred within 1 year of pregnancy every year and do as much information gathering as we can about these women. So we try to pull together medical records, police records, if applicable, anything that we can learn about what happened during this time, and bring those narratives, those cases to the committee to think about. And this is where earlier Jenny was talking about making space and taking space. This is where we really do provide that time and that space to each of these cases, each of these women that have passed in Arizona within the past couple of years, to review what happened and really think about those factors that contributed to the death and that could have potentially been avoided. And so in those cases, once we have all of those recommendations, we're really able to start thinking about, all right, what are some of the systematic issues that are happening either over and over again in Arizona or never should have even happened in the first place, to start thinking about those recommendations and implementing them with our community partners. So like I said, up until this point, just a couple of months ago, we have been unfunded in this way, but we have recently received 2 major grants to help us move forward with more of the community building and quality improvement processes with partners across our state. The first one is from the CDC. They awarded us $450,000 each year for 5 more years to really strengthen our review process so we can be a little more thorough and a little more formalized in our processes, but then take that data and put it into action. So start working on some of the quality improvement efforts with providers directly. We'll talk to you more about that in a second too, but this is going to be a really important step for us to start using the data that we have and what we know to start making real change in our communities. And the second grant that we received right around the same time is from HRSA. It's also about $450,000, I think, each year across 5 years. $2 million per year across 5 years. Sorry, my math is bad. But what this grant does is it does help us with some of the data piece too and some of the quality improvement stuff with providers, but it's helped us establish a maternal health task force that's going to provide some ongoing guidance and strategic direction around where the state and other partners, other community providers are going to be going as well. And then it really helps us go to that next level of innovation, of trying to do some education with women and families, trying to pull together provider clinics and partners that we haven't really worked with before. Like we really want to start working with tribal partners in a way that we haven't yet, other community groups as well. So between these two grants, we really do have sort of the funding, the foundation, the resources, and the energy to start doing something about this issue. So we're going to leave you with just a little bit of information about our next steps. The first one is our Maternal Mortality Action Plan, which really sets our vision for the next 5 years across these two grants and other programs at ADHS. The goals around these are, similar to what you would see in other types of healthcare, but we really want to focus them in on the maternal health space. So we're trying to raise awareness among women and families about warning signs during pregnancy and postpartum. We're trying to improve access to care and really improve workforce capacity, like Kate was saying, when we're looking at the access to care across maternity deserts and limited access to care in our state. Really trying to think about what we can do across workforce capacity and systems of care and things like that. We do have two lofty goals that we're aiming towards. So within 2 years, we'd really like to see a reduction of maternal mortality by 5%, and over 5 years, we want to reduce that by 10%. So those are big goals, but we think that by strengthening these partnerships and strengthening our systems of care that we can achieve that. And one of our strategies for doing this is through the Alliance for Innovation on Maternal Health. I met someone earlier who had heard of this before. Basically, this is a national initiative where states are joining this alliance to adopt quality improvement strategies. They have these safety bundles is what they call them around different topics that you can adopt, and it has all the tools that you need. It helps groups provide technical assistance to providers and things like that. So we've just joined this alliance, and we are hoping to start piloting a safety bundle later this year, and then we'll roll at least the first bundle out later this year, early next year, and then just continue until we get through all of these bundles. Some of them are clinical related to hypertension and hemorrhage and other things that Kate talked about, but some of them are social related to thinking about bringing families into decision making and looking at social determinants of health when you're working with women and that kind of thing. So I know you're dying to read all of the additional statistics that we went through today. All of our reports are available online. We're actually working on a revamp of our site too, to where you can see some more real-time data through some dashboards. And of course, you can link to all the other programs that this state offers as well. So we invite you to check out our website and also invite you to connect with Kate and I and our colleagues here afterwards if you have any thoughts or any ideas, offerings, want to join our committee. We'd love to have you. So yeah, with that, thanks again to fourth trimester, and we'll take questions.
Just to say, if you go back one slide, for the website, you can also just go to azdhs.gov/maternal health, and that'll be a shortcut to this. So it's a little easier to remember.
Have any questions or any comments? I'd say we're all within the same bureau. So yes, we're working together day in and day out. Do you want to talk about how we work specifically?
Yeah, so part of that action plan, there's those 5 overarching goals. Each of those has a multitude of steps within it. So one of the things for both the awareness piece for goal 1, which is increasing awareness on postpartum warning signs, really empowering families and women to know when to seek care. And because that's kind of the first step, right? And then as well as the access to care is utilizing our home visitation programs. So we have McV. We also have 2 other home visiting programs here in Arizona. And so working with them to expand their service area and also work on getting more women eligible to be a part of those programs so that we can continue to support them, whether it's mental health resources, which we know is a big deal, or again, postpartum warning signs, or kind of just giving them tools to improve their health and to be on alert for if these things happen and what to do. So those are part of that kind of overarching that we just, again, that action plan is available online if you wanted to see every piece. Do you want to repeat? Are we repeating the question? Yes. Sorry, we're recording.
So the question was, Arizona has the McV program, the Maternal Infant Early Childhood Home Visiting Program. How does this program cross-reference that?
Any other questions or comments? Are you feeling inspired after this session? Yeah.
How many other states have maternal mortality review committees in terms of how does Arizona compare to other states?
I believe overall more than 40, between 35 and 40 states have some sort of review committee. The process that we use is the CDC Review to Action, which is a kind of a designated, it has tools, it has a very specific guideline in how to do that review so that it's more nationally comparable. And that's what we do here in Arizona. The number of states doing that is closer to 30, I think. And they also provide like a dashboard database kind of situation that we do the review through as well. So there's varying levels. On the first grant that we received from CDC to improve our maternal mortality, I believe about 25 or 27 states received that grant. So we were one of, about half of the states doing the review. And then the Maternal Health Innovation Program grant that we received from HRSA, which is the much larger grant, there were 9 states that were selected for that. So we're being recognized, I think, at a national level for what we've been doing, even without funding. And the fact that we were able to put together this action plan that shows a lot of promise, and we have a lot of community partners, and so it's not just us here in the agency. So it's really exciting to be at that point, and there's a lot of kind of political will and just momentum, I think, in this moment to really kind of move forward. So that's great because Arizona can kind of become hopefully a model for other states as well in some of these pieces that we are able to roll out in the next couple of years.
I actually have a question. In regards to the maternal mortality rate, how do we compare to other states?
That part I'm having a harder time remembering. Do you remember offhand, Martine?
We're 27th?
Yeah, I was going to say somewhere in the middle of the pack. And that's just overall. I think if we were to look at some of the specific like racial groups or other subgroups, that might be a very different story as well. Obviously, not all states have a robust American Indian Alaska Native population, for instance. So that's why some of the things that have been really focused on African American and Black moms, because that's a huge disparity we've known about for a long time. A lot of those things haven't been transitioned even data-wise into this other population. So that's why we're really trying to spend a lot of time and energy working with our tribal communities so that, again, we can use that as a model for other states in a population that obviously is very affected by this.
So I actually had a comment. Yeah, I want to really acknowledge that you guys came here and you talked to us about something that's a really tough topic. And it's not the easiest thing for anybody to hear or for anyone to talk about, but it's so important that we know, right? And that we're aware that like not everybody makes it out of their 4th trimester or even into it. And that's, something that we need to work on as a country, as a state, as a community. And I'm so glad that you guys now have the funding to start doing this. And if there's any way that we can help, like any way, like we're all here. Like this is why we're here, right? So we would love to be a part of whatever you do moving forward because, that's why we're here, right? Like we want Arizona mamas to thrive, not just survive this phase. So thank you so much for being here.
I was say equally back to that, I probably should have disclosed that I've been in this role for about 4 weeks. And if I would have been here for 5 weeks, I could have answered all those questions like Kate did, but just give me some time. But I have had the best time here today and have met so many partners and have really tried to sort of absorb the energy and the vibes and all of there's just so many different players in this space, in the maternal health space, and we're trying to figure out how to bring them all to the table to address this issue too. So looking at one new partner right here for sure. And yeah, we're definitely looking forward to making more partnerships and relationships with other folks here. So thank you for having us.
Actually, could I say something? Just personally, I want to say thank you for what you do because personally, I was a hemorrhage and a near miss. So thank you guys for what you do.
Thank you for being here too. Thank you for what you're doing as well. That was a positive way to end this, right? I think we achieved our goal. Yeah. Thank you. If there's any other questions, though, we're happy to answer them. I think we still have time, but yeah, thanks to all of you.
If people want to be part of any of this, how can we do it? Where should we call? Where should we email?
Absolutely. So, did I go too far?
Well, so I will say is another email address that again was not on here, and I'm sorry that we didn't include it. If you email maternalhealth@azdhs.gov, that goes straight to an inbox that all of us on the programming side see, and that will get you. You can ask any question for information for how to be a part of the maternal mortality review, how to be a part of the maternal health task force, or any of those other initiatives that we are in. Or you can also, our emails are up here as well. So if you want, you can take a picture or come talk to us later and we can get that information as well. And if you just Google AZDHS and call enough people, if you absolutely take nothing from this, then you can find us, I guess, somewhere. We're not in a cave, we're right down by the Capitol. So, yeah.
Sorry, one more question. The AIM safety bundles that you were talking about, which would in turn make the hospitals safer. How can pregnant mamas know which hospitals have instituted the AIM safety bundles? So when they're deciding who their providers are going to be, they can choose to give birth in a hospital that has a higher safety record.
That is a great question. And to be transparent, when we start piloting this, we're starting with a smaller group of hospitals, so it'll take some time to get there. Heidi or Martine, do you have ideas about how we're working with that? We are going to be partnering with the Arizona Healthcare and Hospital Association, so I'm going to pass that to Martine.
Thank you for that question. So I'm over here, like what Clarke had mentioned. So we're starting with a small set of hospitals, right, to kind of get this going. We just selected our bundle, the bundle that we're going to move forward with. But as we work through it, we have this large group called the Maternal Health Task Force, of course, and within that, there's an AIM implementation group that is really going to oversee kind of making sure that these things are happening according to the bundle. But one of those feedbacks that we can give back is how do we communicate back to the community which hospitals were selected and the progress being done, because that's part of the AIM initiative, the benchmarking and making sure that it's being implemented with fidelity and that it's actually driving some good outcomes in those communities. So that's great feedback for us to know. Thank you.
Yeah, and even though we are just as a state beginning the AIM process, there are some of the larger facilities specifically, or in some of these other quality collaboratives that have been ongoing, they have been implementing some of these bundles because the bundles are publicly available. You could Google, I think it's Safety for Every Woman or some similar website we can get you if you really want it. These bundles are available with the toolkits and everything. And what we're doing as a state is just providing some of that technical assistance to roll it out. But some of these things have been already begun to be implemented in the state over the last number of years. So if that kind of information, we do want to make it available to moms to make those informed decisions, along with, the Arizona Perinatal Trust does the levels of care. So that's another piece, right? If you're a high risk mom and you're being seen for high risk, then you're already at a good chance of being in one of those facilities. But obviously that takes some awareness ahead of time. And some of these things are very random, seemingly. So having the information really is helpful. Yeah.
So I know that in California they did a longer range study. I think it was a year postpartum for moms. Are we looking ahead to anything like that to really encompass the fourth trimester? Because we're saying that as soon as moms walk out the door, we're not tracking them, or are we tracking them and it just looks different than this?
For morbidity, in addition to, yes, so that's a next step for us. We had just started the overall analysis last year using so the AIM does the safety bundles. They also, because they're part of their collaboration between ACOG and CDC, they also have a method for looking at severe maternal morbidity, and that's what HRSA tracks as well. And it was using that algorithm that's very specific to that database availability. And so that's why we are just looking at that delivery hospitalization as of now. But obviously we recognize that there's a whole, almost a year in both directions. So the key is just trying to find where that data is available and how to find those women. And so that's something that we're working through actively, and looking at what other states have done is going to be part of that. We just, with the funding being new and things too, we're getting to a place capacity wise that we're able to do a more expansive look. Yeah. But yes, because it is important and delivery is just one very tiny piece of it. So did you have a question?
As a mom who takes her care into her own hands, what are some things I could ask my provider to make sure, things that I want to look out for myself?
So the one, and this is another piece of the action plan, but I know earlier today there's a workshop on those postpartum warning signs from the A1 that has a tool for that. If part of what we're hoping to do is help and empower facilities to implement that at discharge, or even prenatal care or even emergency care providers, anytime you're interacting with a woman, kind of giving them that information, sending them home so they know what to look for. Especially in the postpartum period where your first visit is 6 weeks after, maybe 2 weeks, maybe if you're seeing a pediatrician, but we know that the care is not as consistent as what you just had leading up to your delivery. So I think using that kind of tool, and if you want that tool and if you want to share that tool, they had it here today, but we are more than happy to help connect you with that, because it's something even you could put on your fridge, and it's saying, if you are feeling this way, or if you have a headache that lasts this long, or all these different things, kind of just be aware of. Don't write it off as being like, oh, I just had a baby and I'm tired. That's what I think a lot of women do, and then it gets much more severe by the time they actually do seek care. So that's a key, I think. In the prenatal period, making sure that you find a provider that you connect with and that you feel empowered by, and that you are honest with them about your experiences, and kind of everything else that the rest of today has been talking about as far as making a postpartum plan. I think this is the next session. There's a lot of those kind of toolkits. And so I think being proactive is step one, and then finding the tools and the apps and the things that are available for moms to help make some of those. We are not clinicians, so some of the more specific details about how to do that are kind of outside of our scope, but we can help connect you with people that are really good at that.
We're not clinicians or moms, so
that's also true.
You can just drop the mic. That was pretty. Yeah. But there are lots of people here that we could ask about that for sure.
Well, and that's why another piece of this is also just trying to engage the community as a whole, not just community partners, but families, religious communities. If you're interacting with a mom that's pregnant or just had a baby, kind of helping to be that voice that says, no, you should really go to the doctor, or, because so much already rests on the mom and her spouse to, be aware of things or what they're feeling, and they're tired and they have this new infant they have no idea what to do with, and, it's screaming all the time or whatever that may look like for them. And so to expect them to just always catch these things is tricky. So that's why part of this is not only focusing on providing the information for those new parents, but also trying to get it so that grandparents or sisters and brothers or people can be aware of when to call and how to get that connected. So
we'll also say, I'm going to use that opportunity to plug a new resource that we have at our table and the Southwest Behavioral, not Southwest Behavioral, we have Southwest Human Development tables. Thank you. But there is a hotline, a pregnancy and postpartum hotline too, where if you are experiencing something or just aren't sure where to go, this hotline is sort of a one-stop shop, and they will connect you to resources that are existing, and that will call you back. They make sure that all of the resources that they connect people to are valid and working. So we have plenty of flyers for those as well. Any other thoughts? Any other questions?